Hello and welcome to the part 2 of the Practical Approach to SVT Diagnosis series. In part 1, we focused on building an approach to SVT tracings, formulating the differential diagnosis, and understanding the mechanisms of arrhythmia. In this video, I have a number of tracings and diagrams that will allow us to apply the concepts we learned in the first video. Let's dive right in. When approaching any tracing, never jump into a particular diagnosis. Always start with making a general observation to frame the problem. For example, this is a narrow complex tachycardia. We see the initiation of the tachycardia, the termination, and a few beats of sinus rhythm. The differential for this includes atrial tachycardia, Avnrt, Avrt, and junctional tachycardia. This narrow complex tachycardia initiates with a premature atrial contraction followed by a long PR interval. Then we see several beats of narrow complex tachycardia which do not have easily identifiable P waves and a termination. Now the question is, does the initiation with a PAC and a prolonged PR interval help narrow our differential diagnosis? So let's look at each item on our differential diagnosis list and determine whether this observation can be explained by the mechanism of that particular arrhythmia. Let's first start with an atrial tachycardia. In an atrial tachycardia, it is conceivable that it initiates with a PAC, or the first beat of an atrial tachycardia. Then there's a delay in the AV node called a decrement, which is a response to prematurely stimulating the AV node, and this is a physiological response to a premature stimulus. So yes, this observation can certainly be explained by an atrial tachycardia and is still on the differential diagnosis list. Next, let's look at Avnrt. As with our prior examples, it is very conceivable that an Avnrt initiates with a PAC, which blocks in the fast pathway, preferentially engages the slow pathway, and initiates the tachycardia. And the slow pathway conduction manifests as a prolonged PR interval. So yes, Avnrt can certainly explain this finding, and it is still on the differential diagnosis. Next, let's look at Avrt. Avrt very commonly initiates with a PAC, which blocks in the accessory pathway anterogradely, goes down the AV node, where we experience a physiological decrement, as we did with an atrial tachycardia, and then the Avrt initiates. So yes, this can certainly be explained by Avrt. Finally, let's look at JT. It is very unusual for JT to initiate with a premature atrial contraction. However, could this be the first beat of JT? It is possible. However, if this is the first beat of JT, then there has to be a block to the ventricles, which is very unlikely that the block to the ventricles and the JT initiated on the same beat. Hence, JT is quite unlikely and can be removed from our list of differentials. Here we have a narrow complex tachycardia that initiates with a PAC without PR prolongation and has the same four differentials that we discussed earlier. Now let's work through each of those differential diagnoses to see which can be ruled out on the basis of this observation. So the first one is an atrial tachycardia. So an atrial tachycardia can initiate with a PAC and does not require a delay in the AV node to initiate. So yes, this can be explained by an atrial tachycardia. Now let's look at Avnrt. As we discussed earlier, Avnrt is a macro reentry circuit where the PAC that initiates it often blocks in the fast pathway, goes down and engages the slow pathway, and the delay in the conduction that's produced by the slow pathway is required because it gives time for the fast pathway to recover, such that when it gets to this area, it can engage the fast pathway retrogradely, can conduct up, and re-engage the slow pathway to complete the circuit. So this delay in the conduction is required for Avnrt to initiate. So this observation makes Avnrt less likely. Similarly with Avrt, which is a macro reentry circuit, when it initiates with a PAC, it blocks anterogradely in the accessory pathway and goes down the AV node. This delay in the AV node is required because it allows the accessory pathway to recover. because by the time it gets to the accessory pathway, it's now had ample time to recover, and it's able to conduct retrogradely to re-excite the atrium, which can continue and form this loop. So Avrt is less likely based on this observation. And finally, in the case of JT, this could very well be the first evidence of a JT. If this JT focus sits very close to the atrial insertion of the AV node, it can come up and make a retrograde P wave, and then it can come down simultaneously and take longer to get to the ventricles to create the QRS. So yes, this could be explained by JT. Determination of the arrhythmia can certainly hold clues and help exclude some items on your differential diagnosis list. This is a narrow complex tachycardia. We're given a termination and we're given 2 sinus beats. The narrow complex tachycardia has the same differential diagnosis list: AT, Avnrt, Avrt, and JT. As you can see, P waves are visible within the narrow complex tachycardia, and I can verify that these are P waves because there's a high frequency deflection on the tail end of the T wave that's not present when I template it against the sinus rhythm T wave. So these are certainly P waves. Now the interesting thing about this tachycardia is that it ends on an atrial activation, on a P wave. Now let's look through each item on our differential diagnosis list to determine if we can rule them out on the basis of this observation. First, let's start with an atrial tachycardia. For an atrial tachycardia to terminate on an atrial activation, the mechanism of an atrial tachycardia would have to stop, and then the last beat of the atrial tachycardia would have to block in the AV node such that it activates the atrium and not the ventricles. To use atrial tachycardia to explain this observation, 2 isolated events would have to happen at the same time, at the same cycle. So the atrial tachycardia would terminate in its mechanism, and the last atrial activation would block in the AV node. It would be quite a coincidence for the 2 to happen at the same time, hence atrial tachycardia is very unlikely. Now let's look at Avnrt. Avnrt can certainly terminate like this. When the propagation goes down the slow pathway, comes back up the retrograde fast pathway, it can create an atrial activation and then come down the slow pathway and block in the slow pathway such that there's no ventricular activation. So this can certainly be explained by Avnrt. Now let's look at Avrt. For Avrt to terminate on an atrial activation, the signal must travel down to the AV node, make a QRS, come back up the accessory pathway, make the last P wave, and then block in the AV node without making it to the ventricles. This is certainly a plausible explanation, and Avrt is certainly still on the differential diagnosis. Now let's look at JT. To explain this observation with JT, the last beat of JT would have to make it to the atria, to activate the atrium, make a P wave, and not make it to the ventricles, essentially block below the level of the JT. So 2 things would have to happen. The JT would have to terminate, and the signal would have to block below the level of JT on the same cycle, which is quite a coincidence. So hence JT is quite unlikely on the basis of this explanation and can be ruled out. This is a tracing of a narrow complex tachycardia. Next, let's talk about the concept called VA linking. Here we see 2 sinus beats and initiation of a narrow complex tachycardia, which has the usual differential diagnosis of AT, Avnrt, Avrt, and JT. This narrow complex tachycardia initiates with a PAC followed by a slightly prolonged PR interval. And as we learned in the previous example, this does not help us rule out any of the differential diagnosis items. However, there's something here that may be helpful, and that's called VA linking. The VA time is measured from the onset of the QRS to the next P wave, and it can be measured over several cycles at the initiation of the tachycardia. As you can see, there's slight wobble in the cycle length of this tachycardia. However, the VA time stays completely fixed. This suggests that this QRS is mechanistically linked to the following P wave. Now let's use this observation to go through our differential diagnosis list to see what we can rule out. In a case of atrial tachycardia, each cycle initiates with an atrial focus, then you have an atrial activation that produces the P wave, which then conducts to the ventricles and activates the ventricles to produce the QRS. Each QRS that's produced is related mechanistically to the prior atrial activation or the prior P wave and has nothing to do with when the next atrial activation will take place. So the VA linking helps rule out an atrial tachycardia. This is especially helpful at the beginning of the SVT when then there is a wobble in the tachycardia cycle length, which can be caused by the PR prolongation or simply a ramp up and ramp down phenomenon of an automatic atrial tachycardia. Now let's look at Avnrt. With each cycle of Avnrt, the slow pathway engages the fibers that lead directly to the ventricle and the atria. So the ventricles are linked to the atrial activation. So certainly AV node reentry is possible. Now let's look at Avrt. With each cycle of Avrt, the signal goes through the AV node, makes a QRS, and then comes back up and activates the atrium. So each P wave is mechanistically linked to the prior QRS. So VA linking is possible in Avrt. Now let's look at JT. With each beat of JT, there's a signal that goes up to activate the atrium, and there's a signal that comes down to activate the ventricles. Both of them are linked together as well. So presence of VA linking does not exclude JT. So the only thing that is excluded by VA linking is atrial tachycardia. In this particular example, the VA is not linked. Go ahead and work through each of the differential diagnoses to determine what can be ruled out. You'll find that none of the differentials can be ruled out. The retrograde limb of macro reentry circuits, the one that causes atrial activation, can decrement, which can prolong or shorten VA time. Hence, absence of VA linking is not helpful in ruling out any of the diagnoses. The last feature that we'll talk about that will help you with your differential diagnosis is the AV relationship, or the Rp time. The Rp can be very short, and almost so short such that the QRS and the P wave are overlaid on top of each other, and you get the summation of the waveform. The Rp can be slightly longer, but less than half of the RR cycle length, and in this case, this is considered a long Rp tachycardia, where the Rp is much longer than half the cycle length. Now let's look at the case of a very short Rp tachycardia. In fact, the VA time here is so short that the P wave is merged with the tail section of the QRS. Now let's work through all our possibilities to see what we can rule out. If this is an atrial tachycardia, this P wave would represent the atrial activation, which would be followed by a long PR interval, which would represent the delay in the AV node before ventricles can be activated. So the patient would have to have a first-degree AV block during atrial tachycardia for it to be explained by this observation. This is possible, but not very likely, so we can put atrial tachycardia lower in the differential diagnosis list. Next, we can look at Avnrt. In fact, what you'll find that this is actually a classic case of Avnrt, where the slow pathway engages both the fibers that lead to the ventricles to cause a QRS and the fibers that lead to the atria that cause the P wave. Those fibers are engaged simultaneously. And so the AV time, or the Rp time, in the case of Avnrt is a pseudo-interval. They take place simultaneously, which is why the QRS and the P wave are often overlapped. So in this particular case, Avnrt is the most likely diagnosis. Next, let's look at Avrt as a possibility. In Avrt, the signal must pass through the AV node, depolarize both ventricles, before it can turn around and re-engage the accessory pathway to create another P wave. Generally in Avrt, the P wave must be separated from the QRS. So a lot of electrophysiologists would look at this and say the VA time here is much too short for it to be Avrt, so it can be safely ruled out. And finally, in the case of JT, with each JT focus, with each JT cycle, there is also a pseudo VA interval where the fibers are engaged that lead to the atrium and the fibers are engaged that lead to the ventricle at the same time. So it is very likely that this could very well be JT. Avnrt, or typical Avnrt, is far more likely and more common than JT. So it's still higher on the differential diagnosis compared to JT. Finally, let's look at the case of a long Rp tachycardia and play through all the scenarios. In the case of atrial tachycardia, this could be an atrial tachycardia if this P wave represents atrial activation followed by ventricular activation. Although most would say this interval is far too short to represent physiologic PR interval. Although it could be long enough, it's hard to say. Atrial tachycardia is still a possibility here and cannot be ruled out. In the case of Avnrt, this cannot be a typical Avnrt because there's such a long delay between the ventricular activation and atrial activation. So this has to be a typical Avnrt, but it's always a possibility. Atypical Avnrt can explain any Rp interval or any AV time. In the case of Avrt, this could be Avrt. However, when the ventricle is activated, there's a long delay before the next P wave is formed. So if this pathway is decremental or very slowly conducting such that it creates a very long VA time, it is possible. So an Avrt with a decremental retrograde accessory pathway is a possibility. And finally, with JT, it is a possibility if the JT focus is very close to the atrial entry into the AV node, such that when it fires, it creates a retrograde P wave and then takes a while to create the QRS, which is why the QRS comes after. So it is the JT is also a possibility here. To summarize, a highly effective approach to arrhythmia interpretation is to initially make an observation about a tracing and frame the problem. For example, this is a narrow complex tachycardia. Then present the differential diagnosis and play out the mechanism of each differential against the tracing to see what can be ruled out. We discussed a number of scenarios here, but this is certainly not exhaustive, and the more you practice, the better you'll get. Thank you for your time, and I hope you enjoyed this presentation.